Hi, my name is Benjamin Linus. I'm a professor of medicine at Boston University School of Medicine, and I'm the principal investigator of the Syndemics Lab at Boston Medical Center. The Syndemics Lab at BMC is deeply engaged with the Healing Community Study and the HEAL Initiative more generally, and that's been the context of our work. And so we decided to use the researching effective strategies to prevent opioid death, or the RESPOND simulation model, to experiment with different approaches to reducing overdose, to characterize combinations of interventions that could lead to a 40% reduction in overdose in 2 years. At the end of the day, there were 3 high-level takeaway messages from our work. The first is that there's no single intervention that can end the overdose crisis. To reduce overdose mortality really requires all the tools in the toolbox. A corollary of that is that initiating people on medications for opioid use disorder is definitely essential, but that by itself is not enough to end the crisis. Beyond expanding the reach of medications, we also need to find innovative solutions to improve retention and care, because we get synergies when we both expand access and also improve retention, and we need to capture those synergies in order to reach our goals. And lastly, we found that distributing naloxone is absolutely essential to reducing overdose rates, but is not by itself enough to reach goals. The following presentation is a summary of all of our findings in more detail and should make clear a lot of the dynamics that we discovered with our work. But I'm going to talk today about what models can tell us about ending the opioid crisis. Next slide, please. So the first question, when I say model, I mean a simulation model. And why use simulation models? And I'd point out I'm an investigator, co-investigator in the Healing Community Study. I'm sure that many folks are here as well. And that the HEAL Initiative in general defines a goal of reducing opioid overdose by 40% in the United States. But it's really not clear what it would take to reach such an ambitious goal. And simulation models are a really powerful tool that allow us to integrate data to project scenarios and explore counterfactuals. And at the end of the day, models allow us to ask what if type questions. And they allow us to experiment with an alternate world without hurting people. They also allow us to experiment with many different options that we might not be able to put into reality all at the same time. So models, I would argue, are a really useful tool in this sort of situation where there's a big task at hand and really not a lot of clarity about how to get to the ultimate goal. Next slide. So how do models work? Next slide. This is a graphic of the most simple simulation model a person can make. This is a state transition model with 3 health states: well, sick, and dead. And the way that simulation models work is they simulate the clinical progression of a cohort of individuals throughout the course of their life. And they do that as a series by simulating a series of transitions between these health states. So we set a model time step, say 1 week or 1 month, and the model then creates a little person and sticks them out into the simulated world and advances the clock step by step. And in each step, it rolls the dice to determine in what direction the person might go. And so a person who's well in any given time step could become sick. And if they become sick, then the next time step, they could move to the dead health state, or perhaps they get well again and move back into well, right? And of course, everyone can, even if you're well, you can always get hit by a bus and die. And so there's all these sort of, in this simple model, there's these arrows that you see, and the model simulates an entire lifespan by just walking people through each of these health states until they die. And then it logs all their information. And at the end of the day, we can calculate things from that. If we count all the time steps that a person was not dead, that's that person's simulated person's life expectancy. We can put weights on those health states that might be less than 1 to represent sickness, and that's a quality adjusted life expectancy. And we can also stick costs on each of these health states and tally those as we go. And those become things like projections of lifetime medical costs, which are all the outcomes one would need to do a cost effectiveness analysis. So really, at the end of the day, when we talk about simulations, this is what they are. Next step. I'm going to talk today, or next slide, sorry, talk today about a specific simulation model called the RESPOND model. It's a little bit more complicated than the sick, well, dead. But at the end of the day, it's really the exact same thing. There's just many more health states to keep track of. And so the RESPOND model is a simulation of opioid use disorder in a population in a state, not a health state, sorry, a jurisdictional state like Massachusetts. And at the core of that simulation is the simple 4-state simulation of opioid use disorder. So these are the 4 states of opioid use disorder in our model, and they're defined by either a person can be active or non-actively using. And you see on the left, non-injection use, or on the right, active injection use, right? And you can see there's models going between all of these health states over the course of the simulation. But that's the core of how we simulate opioid use. And I'll say that when people are in active drug use states, be they non-injection or injection, they have some risk of overdose, their healthcare utilization tends to be higher, and they also might start to seek treatment because they're actively using drugs. Also, their quality of life will be lower because they're actively using. Flip side, non-active states, those things tend to get better. Costs tend to go down, quality of life goes up. There is no risk of overdose when not actively using opioids. And then I'll say that injection drug use is similar trends, but more extreme than non-injection. So costs are still higher. Overdose risk is highest in active injectors, et cetera. Next slide. And then this simple 4-state simulation is embedded into a larger simulation of care seeking. And so you'll see there's these large boxes right in the middle where it says no treatment. And then the model can simulate through those thicker arrows movement onto treatments. And the model we're talking about today can simulate outpatient buprenorphine, methadone, naltrexone, and it also does an explicit simulation of acute inpatient detox. And one last model structure that I'll point out for folks on the call is you'll see these sort of teal colored thin rectangles that say post-treatment. That post-treatment is a separate health state that everyone goes through when they leave a treatment or when they leave detox to represent that period of elevated risk of overdose after a period of abstinence. And we can experiment in the model by turning on various arrows that I don't have shown on the slide, right? If we wanted to experiment with, say, initiating MOUDs in detox, which we're going to look at in one moment, it's possible to say, great, if you initiate in detox, we can link you right back out to the community and you don't have to go through the post-treatment state. And so sometimes in the work that we do, avoiding this post-treatment state is one of the most important effects of the intervention. Next slide, please. So with that super brief look at approach and methods, I wanted to ask the first question. One of the first questions we asked with our model is, what would it take to actually get to a 40% reduction in overdose in the United States? So this is a piece we published about a year ago. Go ahead and next slide. So our general approach for this was to use our model, and we wanted to simulate 3 tools to end the opioid crisis. One is initiate more people on MOUDs. A second would be to improve retention on MOUDs. And a third would be to distribute more naloxone. And we experimented with different community types, which we defined in terms of rural communities versus urban communities. We also looked at different degrees of existing infrastructure at baseline. And our goal was to come up with 8 different community archetypes defined by rural and urban and degree of existing infrastructure at baseline that communities could sort of map themselves onto and use these data to try to understand how combinations of these interventions might work together to get to a 40% reduction in overdose. Next slide. These are the main results of the study. I know this is a pretty thick slide, but we're going to walk through it. These are heat maps of the outcomes. And so the first thing I'll ask everyone to do is to ignore the square on the right and only look at the one on the left. We'll get to the right in a moment. Right at the left here, what we're looking at is a heat map. This is representing an urban community that has very little naloxone and very little MOUD and very few MOUDs going on at baseline. And the way to use this heat map is to start in the top left corner, which is what we call the status quo. So that's our best estimate of what's happening at baseline, which is that about 2% of the OUD population are starting an MOUD in any given month. And if you look then down at the horizontal axis at the bottom, it's showing you retention on buprenorphine at 6 months, right? And you'll see it says 34%. So top left corner, we're saying that actually only about 2% of people are starting buprenorphine in any given month. And when they do start, only 34% of them are retaining for at least 6 months. And then as you work down the vertical axis, you're looking at increasingly larger proportions of people entering into buprenorphine, right? So this is basically looking at increased initiation on bup. And if you go across the horizontal axis, you're looking at improved retention and care. And so if you choose any point, say 4% on buprenorphine and 38% retention, right? If you draw the intersection, you get to the square here, and the number says 11. That means that it represents an 11% reduction in opioid overdose compared to the status quo. And the color just correlates with the number to make it easier to look at. And lastly, just to make it easy to look at, this red line that I drew represents the threshold of 40% reductions. So everything below and to the right of the red line represents a 40% reduction or greater. And so high level, I'm not going to go through and look at all the various combinations, but if you look at this, first of all, what we noted was actually there's nothing we can do by itself that's going to get us where we need to go. Because for example, if we only wanted to go all in on just initiating people on buprenorphine without thinking about anything else, even if we went it would take about a 9-fold reduction. So right, 9 times more people initiating on MOUD on buprenorphine every month in order just to touch the 40% reduction. Similarly, if we went only on retention, there's no way to get there, right? If you go across the top row, it never gets to 40%. The only thing that really gets to 40% are combinations in the middle. Now, if you move to the right side, it's the exact same thing, but now what we added in was an additional 294 kits of naloxone distributed per 100,000 people with OUD in the community. And right off the bat, what you can see is, well, first, that if all you do is the naloxone, right, stay at that top left corner, you don't get there, right? Naloxone by itself won't get to 40%. However, it did make the red line come up quite a bit if you compare the left to the right. And suddenly it's looking maybe a little more feasible that if we did some naloxone and also, you know, a major effort, but took it from 2% to 6% of people, so about a 3 times increase in MOUD initiation, and also focused on retaining people in care such that we got at least about half of them to retain for 6 months. Now we're starting to get pretty close to the 40% line. And so we used the study, you know, partly so people could look at what it would take, next slide, but also to make some big picture understandings about what it might take to end the crisis. And what we learned is 3 major messages. One is that there's no single intervention that can end this crisis. It's going to take a combination of interventions. A second one that we thought was very important, because we were doing this in part with the Healing Community Study, and we were bringing these data to community coalitions to talk about their options. We really wanted to make the point that naloxone is absolutely necessary, but it's not sufficient to end the crisis by itself. There's no way out without coming to grips with something around medications for opioid use disorder. And lastly, for more, I think, for some of the providers who were all on board with medications for opioid use disorder, we really wanted to make the point that getting people started is just half the effort. Retention and care is critical, that there really was not a feasible way to get to our goal if we're not also retaining people in care. Next slide, please. So from this, we came to the big conclusion that we really need to identify venues to expand initiation and improve retention on MOUD. And so we've become more and more interested in using this model to experiment with different venues and different models that might have these sorts of impacts to see their cost effectiveness, and what their impacts might be on the crisis. Next slide. So one piece that actually came out digitally in Addiction Today was a paper led by Alexandra Spinica, who is a RA, who's now actually a grad student at Yale. And we looked at detox and just said, what if we used acute detox centers as a place to initiate MOUDs? I'm going to skip the slide because we're starting to run slow. I think people on the call understand the feasibility and the potential of detox as a venue for treating OUD. So next slide. We used our model and we ran some strategies through. And in a long story short, once we said the standard of care, status quo, very few MOUDs in detox, and then we just did some scenarios. One, this light blue one, is we said, what if you just offered everyone who came to detox an MOUD, and about 50% of them said yes and ultimately linked to care. And then just to give a sense of what the possibilities are, sort of the highest end possibility, what if you did this and everyone linked to care? And so what you can see here is that in a cohort of people who go to detox, you see some pretty substantial reductions in their overdose. Right, in the status quo, we're up at about 550 in this cohort, and it comes down to about 400 when you get to the pink bar with everyone linking. Yeah, at the same time, the next slide. This is looking at the population level now, all people in Massachusetts who have OUD, right? And all people in Massachusetts, what might the overdose rate be per 100,000 population? And what you can see is that actually the reduction, right? These are small reductions in cumulative overdose compared to the status quo. So the vertical axis is showing you how big of a reduction do we see? And if you look at the solid black line, that's when about 50% of people say yes and link. We're looking at maybe a 2 to 2.5% reduction in overdoses at the state level. With better linkage, of course, it's higher, but it's still only about a 4.5% reduction at the population level. So, which is not trivial, but it's not 40%, right? And so next slide, please. we said, gosh, it's not just that there is no single intervention to end this. We can't go all in anywhere. It's going to take a lot of different venues. And so I want to keep moving so we have a little time to discuss, but next slide, one more venue we looked at is syringe service programs. Clearly, syringe service programs could have potential. I know that there are debates amongst harm reductionists and treatment providers, and is it okay to offer treatment at a syringe service program? But we wanted to set that philosophical debate aside and just ask, what if we did? Because there's a lot of active injection drug users coming there, and it seems to be a very enriched population. Next slide. And so what we showed, we modeled a strategy where one could offer MOUD to people who come to syringe service programs. And we assumed a small proportion of them would say yes, but that when they did say yes, based on data from pilot intervention syringe service programs, that the retention and care at syringe service programs goes up compared to community-based programs. And what you can see here, again, at the population level, this is projecting cumulative fatal overdoses. And in the black line is the status quo, and the dotted line is the intervention. And you can see here there's some pretty substantial reductions in overdoses because we're intervening at such a high-risk population. And by 2030, I'm reading off the vertical axis here. We're looking at about 15,000 cumulative overdoses in this population compared to over 20,000, 22,000. Go to the next slide. The other thing that was fascinating about this, and I'm just about to wrap, is that this slide shows the relative savings by healthcare spending savings by initiating MOUD in syringe service programs. So in this, compared to not doing that. So in this graph, the downward bars are showing you the relative savings compared to the status quo. And an upward bar would show you that there's actually cost compared to the status quo. And each bar represents a different scenario or different sensitivity analysis. Right? On the far left is the base case. That was our best estimate of all parameters. And then we did scenarios like, well, what if 40% of SSP clients, or only 40% are actually injectors and many are non-injectors? What if 90% relapse after leaving their SSP treatment, et cetera? And what I want to point out here, these are nearly all downward going bars, which is actually very uncommon in cost effectiveness work. Generally, things that work give benefit, but they also cost money because people live and then they have other healthcare problems and we need to take care of that, which is fine. That's why we have a healthcare budget. It's not to save money, it's to get people healthy. But in this case, it's a rare situation where actually, because the risk is so high, because the population is so enriched, providing MOUDs and SSP can actually save money and save lives. And the last point I'd make is this one upward going bar is where we made a scenario where we imagined that actually outside of the SSP, if one were to just begin buprenorphine at a community-based clinic, the retention at that clinic was much better. If that's the case, then it was still a cost-effective thing to do to start MOUDs at SSP, but it was no longer cost-saving. It was just cost-effective. So it's just another example, another way of looking at the fact of how important retention is, because when we play with retention, we can change the findings of these studies. Next slide. So that's about it. Big picture. Oh, sorry. What we learned from syringe service programs. We can skip this slide. I think I already hit that. But where else can we go with MOUDs? That's what we're starting to think about now. Residential drug treatment programs, emergency departments, as Dr. D'Onofrio was just talking about, correctional settings, mobile vans, where else? I think it's a really important question. I think both on the initiation side and on the retention side, it's becoming more and more clear to me, at least, that if we're going to do this, it's going to take some innovative thinking and some new models of care. Next slide. So last summary, simulation models are a powerful tool to characterize a world without an MOUD crisis. There's no single solution to this crisis. We need all available tools and all hands on deck. But expanding the reach of MOUDs is essential. Initiation is only half the task. If that, retention is critically important. And the economics are on our side, fortunately, but the cost of stigma is really, really high. And I'll just say, the fact that we don't do MOUDs in syringe service programs, in some sense, that study quantifies the nature of the stigma. That's how much we're willing to pay in order to maintain our sort of current mode of thinking or moralistic thought about where MOUDs should go or not go. We're willing to both pay money and allow people to die to sustain that, which is quite striking. And we have to move beyond, obviously, if we're going to end the crisis.